Yeah, okay. That might sound a little better. Good morning, everybody. Welcome back. Glad to have you all this morning. Today, my pleasure to introduce Dr. Larry Feinberg, who is professor of medicine. He's been in our division. This is his 46th year we just established. And so over that time, he's been a teacher and a mentor and friend to so many of us, and we're just really honored to have him here with us, talking about something new or interesting about a few very interesting topics in medicine. So Dr. Feinberg, thank you for joining us. Come on up, and you want this? I need to turn this off now.
Well, thanks, Brandon. Thanks for coming, everyone. It's good to see faces of friends and colleagues. And for those out there in the video galaxy, thanks for tuning in. I hope you'll find the next 45 minutes to be worthwhile. The information should be new or interesting or both, and it might be information that will help someone. So I'm such a high-tech guy, so here are some passwords that are going to allow this presentation to proceed. I just have to get used to the technology here. This top one is the key one. It's a guiding principle for me, and it stands for do anything reasonable that Brandon asks you to do. And another reasonable thing that Brandon asked me to do is to hold his son, Augie. And it's hardly a reasonable thing, it's a joyful thing. And you won't believe this, but Augie just asked me for some career advice. And I told him that general medicine was a wonderful career. To be someone's doctor, to have all these meaningful long-term relationships, to deal with the broad array of clinical problems we deal with, to be not engaged in nonstop learning, it's a tremendous thing. We're very fortunate. So 3 clinical issues this morning: sorting out normocytic anemia, testing and treating acute pharyngitis in young adults, and we'll examine an underutilized drug therapy option for resistant hypertension. And if you can find a unifying thread in there, I'd be grateful, because there is none. So first off, a very sweet man, 87 years old, semi-retired. He still imports kitchen appliances from his native Japan, and he comes to the office complaining of fatigue, diminished appetite, and a 15-pound weight loss. Denies any cough or fever or gastrointestinal symptoms in his vital signs, and his general exam normal. He's 5'5" tall, and his weight, though, is down to 137 pounds. So he has some laboratory tests performed, and he's anemic. His hematocrit is 30% with an MCV of 87. His peripheral counts are essentially normal: glucose of 104, creatinine 1,1, an estimated GFR of 65. Electrolytes, liver test normal, as is a thyroid function test. So this patient's anemic, a normocytic anemia. You know, if the MCV is 75 or 105, it's usually pretty easy to make a diagnosis. But when you have a normocytic anemia and you do some follow-up tests that are normal, then you've got more of a diagnostic challenge. And some might agree or disagree, but here are 6 core basic tests that one might employ to Assess anemia. Here again, the hematocrit of 30%. Iron studies normal, B12 folate normal, and reticulocyte count and peripheral blood smear normal. So what does one do? Well, this person saw a hematologist, which is a pretty reasonable thing to happen because it was unclear why he was anemic. And this specialist employed one test that clarified the anemia. One test clarified the process. That one test is in this list of 5 tests: a protein electrophoresis, a bone marrow biopsy, a serum cystatin C, a serum erythropoietin, a serum hepcidin. Any ideas what one test nailed this down? Well, it would have the potential, but not in this patient. And in fact, a cystatin C level was felt to be the definitive test here. How many people have dealt with this test? Okay, the nephrologist would be happy to see the people raising their hands, even though we're talking mainly about a hematologic issue. So the cystatin C immersed in a formula generates an estimate of glomerular filtration, and it generated an estimate of kidney dysfunction that is compatible with the hyperproliferative anemia associated with chronic kidney disease. So that's what this appeared to represent, the hematocrit of 30%, anemia of CKD. And it was not something that I had considered because the report was that his estimated GFR was 65. So this was a bit of a surprise to me. So I think there are some people who are not familiar with cystatin C. I wasn't particularly familiar, and the hematologist said to me, I was expecting some wisdom, but the hematologist said, we see this a lot. And so the fact is that the standard estimate of GFR is a creatinine-based estimate, and it will overestimate GFR in patients like this: elderly, thin, diminished muscle mass. Cystatin C is a protease inhibitor in all tissues, and it's really just another marker of glomerular filtration, filtered at the glomerulus, just like creatinine. But unlike creatinine, it's not predominantly derived from skeletal muscle. So the cystatin C GFR formula, that if you look at your reports from the lab, there's a reference to the inaccuracy of the standard eGFR, and you should consider cystatin C. This is not routine, but the nephrologists say when in doubt, when there's something important hanging on a precise measure, like when the oncologists are dosing toxic drugs and that are renally excreted, they are using this routinely now. But this helped us appreciate that this man had renal disease that could account for anemia. This is a slide that looks at the performance of cystatin C compared to the standard estimate, and on the vertical axis is the estimated GFR, and then this is age along the horizontal axis. We're not even out to where this patient was at age 87. He'd be out where the arrow is. And at younger age and normal function in these healthy people, these different measurements are the same. And that's why most of the time we don't need to attend to cystatin C. But as people age, you can see the difference between the orange and the blue gets wider. And as you move out into the 80s, it widens. And this discrepancy can be quite dramatic. So in people who are thin, who have diminished muscle mass, who are elderly, sometimes the measurement of a cystatin C can clarify things, as it did in this patient. This patient had the anemia of chronic kidney disease. So going forward, you'd like to make sure you keep CKD in mind, as well as other causes of normocytic anemia. So I knew there would be a technical thing here somewhere, but maybe I fixed it. Amazing. So going forward, we have another patient, a 70-year-old man with osteoarthritis of the knees, high blood pressure, and early Parkinson's disease. He's fatigued with diminished stamina. His hematocrit's 34%, which is not all that severe, but it was very clear that his hematocrit had formerly been 44, 46%. And his MCV was 90. His other peripheral counts were normal. His creatinine was 0.7. Liver tests and thyroid studies were normal. And so this is a person with a normocytic anemia. And he had this battery of 6 tests. Maybe they're not all necessary, but they proved to be normal. So this is not the anemia of chronic kidney disease. This person's BMI is like 30, and it's just not a situation where one needs to suspect that, but you've got to suspect something else. And what do we do then when we are not sure what the problem may be? Well, we should look it up. This would be one of 100 examples of tables you can get from the literature or up to date, getting to MCV 80 to 100 and looking down at all the possibilities. So of course, we all admire doctors who look things up, and that is what one should always do. But there's another goofy, silly way to keep normocytic anemia in mind. And down here, you have a sequence of 6 letters, consecutive letters that begin with the letter H. This really is sounding goofy as I share it with you, but sorry. And where does the H come from? Well, H's are everywhere. There's hematocrit and there's hemoglobin. There's always an H around. So you borrow the H and you start this sequence of letters. And the letters stand for things like hemolysis, or the anemia of inflammatory disease, kidney disease, liver disease, bone marrow disease, just to have in mind easily the possibilities. J stands for just about anything. And the one scenario that I kind of think of here is the common situation of a mixed anemia in the older adults we care for, 2 or more processes going on that result in normocytic anemia. So we think through this in this patient I've presented, and nothing quite fits. And of course, we spend an extra moment on kidney disease to make sure we're not going to make that mistake again. But that's not the issue here. Sometimes people present who've had an indolent course of chronic liver disease and now have hypersplenism and have anemia, but there was no evidence of that. And of course, if you're suspecting myelodysplasia or some other grim hematologic syndrome, that's usually the ticket to the hematologist. And that's kind of where one might be. But then you remember that, wait a minute, there are all these H's everywhere: hematocrit, hemoglobin, hematocrit, hemoglobin. So there are 2 H's, and the other H stands for hormone deficiency. And this person had a testosterone level that was very low. And this was the anemia of hypogonadism. And, you know, the idea here is not to just point out these oddball cases, but that there's a systematic way or a convenient way we might proceed in evaluating these patients. Of course, looking things up is always number one. This man was treated with biweekly IM testosterone, and 4 months later, his hematocrit was 42%. So this is kind of a goofy little thing. FNATA is the way to think about this. It sounds like a new osteoporosis drug, but it actually stands for Feinberg's normocytic anemia diagnostic aid. So I've talked about older adults and brought up age, but we do see some young people too, and some young adults present with sore throats. Very smooth transition, I think, here. And they present with acute pharyngitis. Last month, we saw a 23-year-old medical student who had a severe sore throat for 36 hours, had no nasal or head congestion, no cough or fever. He appeared ill, but he was afebrile. And his oral pharynx looked like this, and clearly had tonsillar exudate. He also had tender cervical adenopathy. And the natural question, the time-honored question has been, is this a viral illness or is this group A strep pharyngitis? And most clinicians have ways of trying to organize this. The Centaur criteria, I think, have become by far the most commonly accepted guide to making decisions about testing and treatment. And here are the Centaur criteria: fever, tonsillar exudate, cervical adenopathy, absence of cough. So this young man would have a center score of 3. Now, Dr. Centaur has devoted more than 40 years to studying acute pharyngitis. And the center score is used all over the world. I've met Bob Centaur a few times. We served on the ACP's Board of Governor, Board of Regents around the same time. And last month, we exchanged emails because I knew you would insist on up-to-date information. So the center score is quite a legacy. I mean, in comparison, I've accomplished very little. But I have described a new physical finding, a new sign. Severe pharyngitis that makes the throat glow in the dark. And I submit that this is Feinberg's sign. So this medical student has exudative pharyngitis, tender cervical adenopathy. He's not coughing, has no fever. Should we treat this young man with antibiotics and not even bother testing? Or should we test for strep and then treat accordingly? So who wants to treat without any testing? And who wants to test for strep and then treat accordingly? Well, you agree with all the experts out there, with one big exception. Robert Centaur doesn't agree with you. But the CDC and all the infectious disease people feel that we should test these patients. And when I say these patients, we're talking now only about young adults, 18 to 30, acute illness, not someone who's had this lingering sore throat for 10 days since they had a sinus, this or that. Acute pharyngitis. And third, moderately severe pharyngitis, center scores of 3 or 4. If this sounds too cookbooky, well, maybe it is, but it's a guide. So that's the group of people we're talking about. Should we test this young man? The experts say yes. But as I said, Dr. Centaur, who's given this problem a lot of thought, says no. If he encounters a young adult, 18 to 30, with acute pharyngitis, he asks, is it viral? Is it group A beta strep? Or is it another cause of bacterial pharyngitis? And particularly, could this be Fusobacterium infection? Who has heard of Fusobacterium? Okay, for the people out in cyberspace, there are about 3 out of 15 who were familiar with Fusobacterium. There's not a lot of reason to have been familiar with Fusobacterium. Fusobacterium is a gram-negative anaerobe. It's part of normal oral flora. Centaur and others, not just Robert Centaur, but others, believe that this agent causes acute pharyngitis in young people. And most important, it causes illness more severe than just pharyngitis. It can cause peritonsillar abscess, and it can cause Lemierre's syndrome, which is a potentially fatal condition. So it turns out that some pharyngeal infections can involve the retropharyngeal space or the parapharyngeal space, and if they're sufficiently invasive, can involve the internal jugular vein, causing thrombosis and phlebitis, what is a septic thrombophlebitis of the internal jugular vein as a consequence of an invasive pharyngeal infection. And a CT shows a widely patent internal jugular vein here, but the opposite side with a clot. And this is a thrombotic event, part of septic thrombophlebitis, that can result in septic emboli to the lungs, infection of the pleural space. This is a life-threatening problem. Fortunately, it's very rare. So then the question is, does Fusobacterium really cause pharyngitis that could lead to this septic thrombophlebitis syndrome that I just portrayed? And to learn more about Fusobacterium, Center's group conducted a study of 300 young adults at the University of Alabama campus, and they had acute pharyngitis, and they devised DNA probes for Fusobacterium and group A strep. And they published this in the Annals of Internal Medicine a few years back, the clinical presentation of Fusobacterium positive and strep pharyngitis in a university health clinic. And they showed that you could isolate Fusobacterium almost twice as often as you would isolate group A strep. Fusobacterium seen in 15 to 20%, group A strep in 6 to 10%. So that's just a rough idea of how often you can isolate one of these pathogens. Please note that in the asymptomatic control group, the carrier rate for Fusobacterium is around 9%. And this prompts many critics to say they're skeptical about the role of Fusobacterium. It lives in the oral pharynx of almost 10% of these young people. But you can see, of course, that in the symptomatic patients, the yield of culture or DNA probe was higher. They showed in this study that Centaur organized that all bacterial pharyngitis is clinically the same, whether it's group A strep, Fusobacterium, or pathogens we don't think about too much, group C and group G strep, which are likely real deals in terms of causing illness. You can see that roughly a third of patients have fever, 2/3 have adenopathy. Basically, these are all quite comparable syndromes, whichever bacterium you're considering. And just to help in the statements I'm going to make, if we look at these young people presenting with acute pharyngitis, 20% of them over here on the right side, there were over 300 people, 63 had center scores of 3 and 4. So 20% of this young population have what I'd call moderate to severe pharyngitis. 20% of young people presenting with acute pharyngitis are in this center 3 and 4 category. So this is the kind of problem the patient has, and we've seen that Fusobacterium can be isolated from the throat of a young person with pharyngitis. We know that Lemierre's syndrome that I portrayed to you typically begins with a sore throat, And 80% of patients with Lemierre syndrome, it's caused by fusobacterium. So that's the emotional and realistic charge of this whole Lemierre syndrome. It can be caused, however rarely, by fusobacterium pharyngitis. So where are we going with this? We know that if a person like this has a strep test and it's negative, there'll be about 25% of the group that still has fusobacterium, we believe, in their oropharynx. And of course, at the present time, there's nothing that one does about it. For the foreseeable future, there's going to be no test that isolates fusobacterium from the oropharynx. So Robert Center urges us, for now, to treat all these young people with moderate to severe pharyngitis to eradicate fusobacterium and prevent Lemierre syndrome. So this is the leader of the field, and this is what he is using as his rationale for a very different approach. And it may be something that you choose not to do. So, yes, Paul. There is no evidence. So that's, of course, one criticism. It all seems to make sense, but we don't have the kinds of studies that say that if you treat, you'll prevent peritonsillar abscess or Lemierre syndrome. Center would have us believe that it's likely that we would prevent it, but it's not unproven. So if we look at moderate to severe pharyngitis in young adults, people with a center score of 3 or 4, they'd have exudative pharyngitis, adenopathy, fever, but maybe they're coughing a little bit, or however they exhibit these markers. The CDC, I just use that as a surrogate for all the experts out there, say, test these people. And if they're positive for strep, treat them. Pretty traditional approach. Center says, treat them all, don't test. That's quite a different approach. And in my view, you can choose either approach. When all is said and done, without all the nuances, then using the CDC and other expert advice, about 12% of these young people would receive antibiotics, whereas as I showed you, 20% of young people would receive antibiotics if you use guidelines from Robert Center. And so that's really where some of the criticisms comes from. This is not good antibiotic stewardship, overusing antibiotics. And if we're talking about preventing rare things, what about rare things like severe life-threatening C. diff or Stevens-Johnson syndrome or some other severe systemic hypersensitivity reaction? So nobody knows the balance of that. But this is a way of comparing these two. Ordinarily, one wouldn't feature one doctor out there who has these guidelines, but this is a highly respected scholarly guy who's worked on this, and his first publication was in 1981 about acute pharyngitis. Let me just finish this, Mark, and then I want your comment. The antibiotic treatment is the same for most people. Penicillin V or amoxicillin, 500 twice a day for 10 days. It's the same, whichever strategy. The difference comes in people who are severely, or as I've read in the literature, who are anaphylactically allergic to penicillin, real high-risk patients. There is a difference. The CDC and others would say use clarithromycin or azithromycin as the alternative, and Center would say, no, not a good idea, because fusobacterium is resistant to macrolides, and therefore clindamycin would be the drug you would choose, again, in young adults. Mark, you had a question?
Well, I was curious about that. Do we know the prevalence of
Rare. Rare would be the term I would use. I'll show you something in just a second. So there's a lot of uncertainty. but just maybe we're at the beginning of an understanding of the problem of bacterial pharyngitis, where we'll move in the direction that Robert Center would hope we might be tomorrow. But there's a lot of uncertainty. So actually, this addresses your question. This is people who have criticized Center say, well, Meier syndrome is so rare, forget about it. You know, it's just not worth changing our approach. So he developed this hypothetical cohort of 1 million patients. It's actually not hypothetical. Brandon actually has seen all million of these patients. And these are young people under 25 is the particular age region. And he estimates that 10% of these pharyngitis patients had strep and 10% had fusobacterium. And I think some of you are old enough to recall that most of the rationale for compulsive strep testing has been preventing acute rheumatic fever. Yes, there are some other advantages in early antibiotic treatment, but that has been the dominant message for most of my career. So he chose to compare Meier syndrome with acute rheumatic fever. And he felt with his calculations and literature review that one might deal with 50 cases of acute rheumatic fever and 1 death, but you'd have 5 times as many cases of Meier syndrome and 11 deaths. But this is rare. In fact, I think of it as not so much comparing anymore to acute rheumatic fever, but comparing the Meier's picture to the potential for serious adverse drug effects. And I think he or his fellows ought to be doing some type of analysis to look how that stacks up. Life-threatening C. diff. Some people die of C. diff, even young people, and other serious systemic hypersensitivity reactions. So he would emphasize that no matter what you think about approaching patients with acute pharyngitis, again, young adults, that we need to give a little better advice than we probably do. These return precautions, if you will, we need to be more explicit and emphasize that if they're not getting better by day 5, they need to be reassessed in person. If they can't swallow, if they have rigors, if they have neck swelling, some of this is pretty obvious markers for urgent evaluation. And he emphasizes no matter what treatment you provide, you should emphasize these potential complications. Any questions about that? Yeah. Yeah. We have time. I think older adults would be handled in the way that most of you handle these younger adults. So they would not be treated empirically. They would not be treated without testing. And the main biologic reason is they're not prone to fusobacterium. What there is about the biology of the tonsils as we get older that predisposes to fusobacterium. So his strategy does not apply to older adults. And so I think you'd use a test, but there again, not for everyone. Everybody seems to agree that if you have a sore throat and you only have a center score of 0, you don't have exudate, you're not febrile, you don't have adenopathy, you're coughing, nothing. No testing, no treatment is what most experts say, including Robert Center. So center 0 or 1, no testing, no treatment. The real sticky area is center score 2. And you can either not test, not treat, and that's accepted by many people, or you can test them all and treat accordingly. That's an option. Or Centaur, and he devoted quite a bit of one email to this. He feels he can be suspicious about what Centaur 2 patient might have fusobacterium, and he'll treat them empirically. But he's not making a big case, although some of his critics worry that he's starting down a slippery slope and advocating more liberal empiric treatment for milder patients. And that's not where most of us are. Does that answer your question, Brandon?
Is there a test in development to make you diagnose?
Right now, no. And I don't have more information, but right now I called microbiology and they've had maybe 1 or 2 inquiries over the last 6 years, but there's no plan to have some type of simple probe or PCR for Fusobacterium. But they developed it at the University of Alabama for the purposes of their study. Can you handle one more? All right. So let's talk about a person whose blood pressure is difficult to control. This is a 54-year-old woman with longstanding hypertension, no target organ or clinical cardiovascular disease. 4 months ago, a 5th drug was added for blood pressure control, and yet unfortunately, the recent home and office readings are averaging around 158/96. Lab work's normal, and you can see a familiar pentad of medications here. So this is a person with resistant hypertension. Treatment's not successful in achieving goal blood pressure. It turns out that that's a common situation. There's not a lot of success in treating these patients. Of course, there is some. And this data set that I'm about to show you is kind of a neat set of data. On the left are people achieving goal blood pressure defined as 140/90. So as you know, many people would set that goal blood pressure lower, but under 140/90. And if we just focus on the left-hand side here, these would be three medications, antihypertensive medications that these patients were taking, 4,000 of them. And at time 0, with the blue diagonal bar, 70% had achieved goal blood pressure. So they really are not resistant by definition. And a year later, this was the number who were achieving goal blood pressure. No change, no change. Truly resistant patients, 4 or 5 antihypertensive drugs, roughly 70% at goal blood pressure. And over a year's time, from the diagonal blue to the solid blue, no change. So don't know any of the nuances about what was going on, but a rough snapshot to tell us, or 2 snapshots to tell us that we generally don't make a lot of progress in any given year lowering these patients' blood pressure. I hope you feel differently, and I hope you're having more success. So the people at the Cleveland Clinic published a few months ago a review of resistant hypertension. They did this in Technicolor, and they, we're not going through all this, but they basically define the problem as we're accustomed to defining it. Not at goal blood pressure in spite of 3 drugs, typically an ACE or ARB, calcium channel blocker, and a diuretic at moderate or maximum doses. And they define that, and they approach some of these things like medication adherence and home blood pressure readings. And what I submit to you is that you can kind of capture all this in the word resistant to help remember and reassess the basics when you're dealing with this person with refractory hypertension. Resistant, you're reassessing. Is there a secondary cause? Is there an interfering drug? The most prominent would be non-steroidals that blunt the effect of diuretics. Lifestyle issues like sodium and weight, making sure one drug at least is taken in the evening, and the critical aspect of at-home blood pressure readings and the frustrating problem of people not taking their medicine. So this is a way of just keeping in mind a little checklist of the basics as you struggle to move forward with a patient with resistant hypertension. But I really want to talk about one aspect of drug therapy, I list here spironolactone, which is generally the consensus fourth drug. It sounds much too dogmatic, but it's a guide that a mineralocorticoid receptor antagonist would be the fourth drug for a patient like this. And then I have listed next a loop diuretic that probably many of us do not use, but I think is the preferred loop diuretic for patients with this problem. But of course, there are other drugs. There's clonidine and prazosin and hydralazine and minoxidil and others. And of course, they are all legitimate options. But I want to acquaint you with an option that's underutilized. This is another option that may be coming down the road. This was published just a few months ago in the New England Journal. People are excited about this, baxdrostat, which is an aldosterone synthetase inhibitor, and for treatment-resistant hypertension. And if you look at the left-hand bar, the decline in systolic blood pressure, different doses compared to the gray bar placebo. These are nice declines, and a lot of excitement has been the response to this. But I would remind you that none of these patients were on a drug like spironolactone. And it's unlikely that one is going to be combining a aldosterone antagonist with an aldosterone synthetase inhibitor. So this new drug might either be a substitute for spironolactone, or spironolactone's not tolerated and you use this. So this is not some dramatic answer to this issue. And this is actually what spironolactone looked like in resistant hypertensive patients 15 years ago, when we came to realize that this drug offered a lot to resistant hypertensive patients. And so basically we're dealing with a new drug just published in the New England Journal that has comparable blood pressure lowering effects. So it turns out that most people with resistant hypertension are thought to have subclinical volume overload. Their central blood volumes are increased. I'll show you a few reasons why in a second. And this is one of the prominent hypertensionologists from 20 years ago in a New England Journal paper. Because volume overload is common, the most important therapeutic maneuver is to add or increase diuretic therapy. And the question is, why do these people have subclinical volume expansion? Their jugular veins are not distended and they don't have edema, but their central blood volume is increased. And not all of these things apply to everyone, of course, but many of these patients have low GFR, their sodium intake is high, they're on nonsteroidals that counter the effects of diuretics. They have reflex sodium and water retention in response to vasodilator treatment. They've got one form or another of hyperaldosteronism. There are genetic and other factors that contribute to this. And simplistically, if you're dealing with cardiac output, which is usually not an issue and is stable and is normal, you've got a lot of drugs working here at the vascular resistance end. And one can picture that if the capacitance of the central blood vessels is filled and volume overload exists, that pressure would be high, and this might be more diuretic responsive. So the question asked by people at the Mayo Clinic, does attention to volume and use of loop diuretics really improve blood pressure control in resistant hypertension? Because the people at the Mayo Clinic know there are people like Dr. Redstone and Dr. Ernest who want to know this stuff. And they devised a study that has never been duplicated, and that's a weakness, asking this question: if you can attend to volume and use loop diuretics carefully, will blood pressure control improve? And they took 100 people with resistant hypertension, over here in the diagnostic circle, average age of 65, 171/89 was the average pressure on 3 or 4 drugs. That's the group. And they have 4 measurements that are estimates of their central blood volume. That's what the HD or hemodynamic care refers to. 1 measurement at the outset, after 1 month, 2 months, and at the end. where measurements, estimates of central blood volume are provided to the hypertensionologist trying to help lower this patient's blood pressure and allow the doctor to make more confident adjustments, including adjustments of diuretics. Now, it turns out that the specialists at the Mayo Clinic, they're pretty good too, and they know about the hypothesis of diuretic effect. And it turned out at the end, both of these groups were on more diuretic than when they started, although the group getting these volume measurements were on more intensive diuretic therapy. They used a device that generates a low voltage input into the thorax that's measured, and then this bioimpedance gives you this estimate of central blood volume. Although, unfortunately, some people do not do well and are not participants at the end of the study. But the bottom line at the end of the study, estimates of blood volume improve blood pressure lowering and resistant hypertension. The black bars are really the areas of interest. This group started out at 169 over 87 on 3 or 4 drugs, and over 3 months, with the clinician being guided by intrathoracic blood volume measurements, reduced the pressure to 139 over 72. So it's just one bit of experience, but if you ask clinicians at the Mayo Clinic or other referral centers, what do you do that helps these hypertensive people the most? They say diuretics. We intensify diuretic therapy. And this work from the Mayo Clinic kind of supports that. So I think torsemide, which is very much like furosemide, except has a longer duration of action, a longer half-life, so it can do the job when given once or twice a day. Furosemide would need to be given 2 or 3 times a day. Very low starting dose, very cautious, appreciating that this is a drug similar to furosemide with these strange sulfur groups here. But when you want to start with a low dose, you think about the molecular structure and you write it out on a prescription blank and you ask the pharmacist to dispense 1 molecule twice a day. So this person that we presented did well. A lot of people do not do well. They may bump up their creatinine or not tolerate the regimen, but many people do well. Torsemide was substituted for chlorthalidone, very slowly titrated up, and the pressure improved. Not always the case, but it's a very legitimate option. So for resistant hypertension, we've got this little checklist with the word resistant. We've got our 3-drug regimen that's usually in place. Spironolactone, the consensus 4th drug. But if the potassium's high or the creatinine's high and you can't even use a mineralocorticoid receptor antagonist, or the drug's not tolerated or ineffective, one option that I think we underutilize is intensifying diuretic therapy, loop diuretics. So we've talked about a number of things. I just summed up the issue about loop diuretic therapy. We learned a little bit, I think, about cystatin C as a measure of kidney function, and relevant to our discussion of normocytic anemia, that it could allow us to appreciate advanced CKD when we otherwise would have been clueless, as I was. And then we have this silly little sequence of letters that begin with H. How do you remember H? Because H's are everywhere, hematocrit and hemoglobin, and it spells out some of the main categories of normocytic anemia. And then the fusobacterium story, which I think is also new for many of you. And whatever it turns out, to me, it's been such a game changer, or just a dramatic alteration in how one thinks about a common, seemingly mundane problem. But I think it's the real deal, actually. And so one option is to empirically treat patients with Centaur scores 3 and 4 with moderately severe pharyngitis. And again, that's just young adults, 18 to 30. So thanks very much for the chance to talk to you. And we have time for questions if people have any. Yeah.
Before we start cranking away on this direction, because those patients might have it if we start cranking away on the group.
Yes, I think we're at a point where there's a consensus that when people have resistant hypertension, we should be working them up for primary aldosteronism. And it seems quite consistent. I think some of the recommendations about evaluating primary aldo are probably too liberal, but for resistant hypertension, it's a process that's appropriate. I would do that first. Well, someone, no matter what their age, with a hematocrit that's low, certainly 35 would be low enough for me. I'd work them up. So if that's one of your questions, I would not attribute that to age. People have studied hematocrit hemoglobin with age, and there may be a subtle decline, but it's very minimal. So I would never chalk it up to age. And then if the question is how low the threshold would be to get a cystatin C level in an older person with diminished muscle mass, this is, again, relatively new for me, but if I had normocytic anemia, I would consider getting that test instead of doing 5 other tests or referring for a bone marrow biopsy. Yeah. Yeah. Well, Mark, you asked about 5 questions in there, which is fine. I only admire your curiosity. So, as I said at the outset, I would work up anybody who, has a decent lifespan and so forth for anemia, because some of these mixed anemias could hide B12 deficiency or iron deficiency. Those are kind of 2 can't miss processes because of their implications for the health of the nervous system or the possibility of occult blood loss from serious GI tract problems. So, if someone's got years to live, I would be working up most anemic patients. But if you do these basic core tests and you think about other clinical scenarios like chronic kidney disease, and everything comes up negative, this is someone you could monitor and not choose to do bone marrow biopsies or refer to hematology. I don't think those are automatic things. I think you ended with a comment about testosterone. There's a lot of debate about the value of testosterone, even for proven hypogonadal men, in terms of energy level, cerebral function, sexual function, stamina, and so forth. And there's a lot of, but I don't think there's much question that someone with hypogonadism who's anemic can and typically will respond to testosterone, and I think the benefits outweigh the risks, and I would do it. Yeah. Yeah. They got up to 100 milligrams a day, but a lot of the benefit was at 25 to 50 milligrams a day. I'd say the majority of patients showed a significant response at those lower doses, but as long as the potassium is behaving itself, one can push the dose up. And, obviously men may develop intolerable gynecomastia. You maybe switch to a Clarinone, but that's thought to be less effective. So that's where a drug like this baxdrostat, acting on the aldosterone part of this, may be valuable. I mean, we need all the tools in the armamentarium that we can have, but anybody who would look to this recent report and say, oh, that's going to be the answer for resistant hypertension, I believe is, a bit off the mark.